Good afternoon, ladies and gentlemen, and welcome to, once again, the RSM's COVID seminars. And can I first of all just say something to everybody watching this? We're very, very grateful to you for all the feedback that you do give us. And I swear to God, and this, I am literally telling the truth, that we do look at it all, and it is very, very helpful and very encouraging. So thank you. Now then, today, another great opportunity and privilege for us, because my guest today is Don Berwick. Now, if I were to take you through his CV, we'd still be talking tomorrow. So let me just hit the quick highlights. He's been at the center of American healthcare now for ages and ages, certainly for all the good bits for generations. He's a passionate supporter also of the NHS and an all-round Anglophile. He's been at the heart of the safety agenda long before Jeremy Hunt had even heard of it, worked with the Blair government, but also subsequent administrations on many things, including with staffs, and remains a very welcome visitor to our shores. In the States, he's been health advisor to Clinton, advisor to Obama on Medicare and Medicaid, although for reasons that I can't quite put my finger on it, he seems to have lost that job in 2016. Something must have happened over there, I'm not sure what. On the other hand, he's been working closely with the Biden and Bernie Sanders in writing the Unity Task Force report, including healthcare. That's basically what we would call a manifesto, and let's hope to see that comes to practice. Right, Don, welcome to us. Now then, it's a pleasure. So let me start. Now, you had in your characteristic style, a short but pithy JAMA article a few weeks ago called The New Normal. I'm afraid I did ban that phrase a few weeks ago on these webinars, but for you, I will make an exception. And you have one of the best opening lines ever. And I'm just going to quote it to you. SARS-CoV-2 has only 15 genes compared with the 30,000 in the human genome, but it is a very stern teacher indeed. Answers to the questions it has raised may shape both healthcare and society as a whole. A great opener. So you then go through some of the lessons of it. And so let me ask you let's pick number one and ask you to elaborate on it. Your first lesson, everything is going faster. And as you say, clinicians in the new normal, I hate that word, may be less tolerant of unwarranted variation in healthcare. Elaborate what you mean.
I was asked to write about the new normal and refused. I wrote about choices for the new normal, which is like, what is COVID gonna, what could we now do? Because we're learning some stuff and we can use it or we can throw it away. And the items you're referring to are first speed. I've just never seen healthcare at large scale act faster than it is now. You have that example in London of setting up the Nightingale facility at the Excel Center. I'm told by the leaders that it was 3 weeks from thinking of the idea to the admission of the first patient, and you mothballed it. You ended up not using it, but it was there. That's extraordinary. Journal cycle times are going at pace. You just telling me, Simon, before the show about grant making and how the pace of that. So pace is new, and healthcare is famously very slow to change. There's a canonical paper that said it takes 17 years for an idea to go from bench to bedside.
Yep.
Now it's going to be 17 hours. And the other element of that you're referring to is standardization, which is, we constantly have this battle in healthcare that annoys me between physician autonomy, I'll do what I want, thank you, and adherence to standards, guidelines and standards. It's never seemed to me a matter of combat. We all use standards when it makes sense, and physicians do need autonomy. There's obviously a balance to strike. But here I see in the clinical workforce around the world an avidity for finding out who knows more than I do, for drawing in lessons that I find it interesting and frankly thrilling. Within days of the virus hitting Seattle on our West Coast, I know there was a group of Seattle intensivists in very close contact with Wuhan intensive care doctors to harvest all the lessons they possibly could. And within days, there was a document that I received, 3 or 4 single-spaced pages of lessons learned from Wuhan, flying around the United States among clinicians. So those are two choices. Do we want to keep up this pace, the good part of it, and do we want to be more secure about getting the best science into practice everywhere? Those are two of the choices I think we have.
Okay. I mean, it is a concept. On the one hand, we want standardization fast so we know what to do. On the other hand, we're constantly being told about innovation. So we're desperate for some stroke of luck, someone trying something different, pouring bleach into the lungs, for example. No, maybe not that one, but other innovations. But I mean, how do we know at the time which is which?
That's the tension to maintain scientific discipline at pace. And I don't believe they're inconsistent. My career for 30, 40 years has been about rapid learning, rapid cycle learning. And you do it by bringing science to the field, by using methods of inquiry and inference based on changes we make that are disciplined, but they're not ponderous, year-long, multi-year trials. That's important when we're testing a new chemotherapy agent, perhaps for leukemia, but we have much faster ways to learn by simply organizing reflection, dialogue, transparency, and measurement in the real world, in real cycle times. And that can work brilliantly.
Okay, now I've just had a question coming by text. If you can switch the camera to me, folks, so Don can see it. So it's from a Mr. Simon Stevens.
I can't read it on your
phone. Don't worry, I'll read it to you. He
Yeah.
claims to be the head of the NHS. It's always nice to know that someone is. And it says, and here, and I quote, I'm going to read it out. It says here, Don, you are the eternal optimist. What good, it's a little bit more, it's really a pretty general question. I think it's going to let you talk about whatever you want. But it says, what good, if any, could emerge from the pandemic? And what actions should we take to bring this about? So it's the theme really of what you've just written, but anyway, it's a cue from Simon. He has a follow-up question, slightly more tricky, but just pick on one of the things that you, from your optimistic side.
I'll take two, which is
okay. You can take two.
Solidarity and teamwork. Look, you cannot. This virus is too smart to beat alone, and to me, among the great advantages of the NHS has always been the opportunity to be together, to work together on behalf of public interest as a team. And this virus is teaching us we break down the walls where patients suffer. So I would say, please, please come together. This is not a time for fractioning and fighting. I hope we learn that. Those clinicians who we celebrate, they are being a team, and this takes everyone at once. You didn't open the Nightingale facility in 3 weeks by fighting and fragmented. You did it by coming together and saying, let's get this job done. The other lesson, a hard one, the hardest one, and it's not exactly a positive thing at all, but it has to do with equity. We'll talk about that later, perhaps in this interview, Simon. But in the United States, we are reeling from the lessons learned about racism and disparity in this country. And what happened, they've always been there for centuries, but COVID is underlining it and awakening us to it. And then we had this horrible event with George Floyd's murder and the kind of the reckoning with racism. I don't know if your country has the similar.
We do. But, I think we're going to do that, move it slightly, because it's not just about healthcare; it's about other things as well.
Yeah. But, so the answer to Simon's question is: listen up. These problems have been there a long time. Can we please get together and end it? And we'll talk more about that, Simon.
Okay. Now, Simon's follow-up question, the more negative one, and clearly this is based on the news today. He's asking about the state of the anti-science ideological backlash, particularly in the US, conspiracy theories, attacks on Fauci, obvious anti-vax disinformation. How deep-seated is it? And is this a real risk, or is this something we can just shrug our shoulders about?
I can't comment on the UK scene. In the US, it is a serious risk, and it's a leadership failure. We have, for complex reasons, a president in place who does not, let alone doesn't honor science. He doesn't seem to understand science, and he's all too ready to throw away the benefits of science and the scientific method. That is it's a murderous mistake. And, that for us, it's a political problem. We have to get into office leaders who will put science in the proper place with respect and dignity, asking tough questions, but being open to it. I think it's a very frightening turn of events, and it is structural because in this administration, this president has removed science structurally from agencies that must depend on science, climate agencies, healthcare agencies. It's very, very risky, and the public wants answers. They want to feel secure, and when someone offers a cheap answer, it is all too easy to sell it in the short run. I do think we'll get back to to rationality. I think that science will return, but we have a serious problem.
Okay, I mean, by getting back, I mean, we have to remember that there's been a segment that has been irrational even before COVID. So it's not like there was ever a halcyon days where everyone was entirely rational in all their view making and policy making. But that's a fair thing. And Simon sends his best wishes, by the way. Now, but what he didn't ask, now 3 or 4 people have already asked variations on a theme. And it's a question actually that, again, I asked Jeremy Hunt last week, but didn't really get the answer I was expecting, but let's see how you do. And this is the idea that, well, the question is, how do we move from excessive regulation and box ticking without losing accountability and responsibility? And the question I was asking was that during the crisis, the, 12, 16 weeks of which the crisis was in London and other parts of the country, where many of the normal kind of what you might call checks and balances and regulation and appraisal and CQC and inspections were all suspended. The general view is the NHS worked very well, perhaps better than ever. So how can we harness that bit, but without losing the essential accountability and responsibility? I think it's a great question.
It is, yeah. I mean, the answer is use our brains. I mean, so you're referring to a field that I have come to learn is crisis standards of care. When the alarm goes off, when COVID hits, when we're overwhelmed, there need to be standards, but the legacy standards won't work. They can't work. They're too slow and they are too cumbersome, and they actually don't allow for enough agility and adaptation at the front line where people are sensing what the problem is. So it is possible to develop a set of standards which need to be brought into play, and that ability to say, well, what's the new way that we can regulate, watch, measure, and exchange information without tying our hands is proper. A good example would be, say, scope of practice standards, where guild structures and traditions hold very tightly the rights to do certain things in the healthcare world. When the workforce is overwhelmed, you had better find new ways to let new people show up and do things that they can help with. So I think it can be taken formally seriously, and a smart country or a smart organization would have developed in advance what those standards look like.
Do you have any examples of that actually happening, in which we have backtracked, as it were, by using the phrase excessive regulation? Obviously, no one can ever be in favor of excessive anything. But if we just said regulation and we avoided the pejorative word box ticking, again, which is obviously clearly expecting a certain answer. But do you know examples in which this has actually happened, where people have decided to reduce regulation without, good examples, without challenging accountability and responsibility?
Yes, a small example is professional licensure. For example,
Okay.
I'm a retired physician. I don't see patients anymore, and my license is no longer in force. Our board of registration in my state and in many states has made a call out to clinicians saying the usual process for getting your license back is too long right now. We need more people at work. So we've created a fast track way to get your license back. It's responsible. It's not just ticking a box, but it goes much, much faster. I haven't done that myself, but lots of people in many states have now been able to come out of retirement, get back to work under safe conditions with some form of extra supervision, and it's worked fine. And by the way, the workforce has been more than happy to do that. Literally thousands of retired doctors and nurses have showed up and said, I'm ready to help, get me back on the line. That would be one small case.
Okay.
I think the ability to exchange information. We have very tight patient protection rules, privacy protection rules, as you do in England. But now it becomes really, really important to be able to move information around about who's trying what's happening with patients. And although I think there's still discipline there, the regulations have flexed so that information can be exchanged more easily. Telemedicine is another example where we have been, I think, over-regulating telemedicine and restricting it for a long time. And now, my goodness, I mean, it is now blossomed so that I have a medical appointment next week, and they called me yesterday and said, would you rather do it by telemedicine? The answer is yes, I would. I spoke to a head of a health center that this last week has said they've gone in 1 week. They went from 5% telemedicine visits to 95%. That's required flexing on regulations.
And my wife will give a similar story in general practice, and I fell off my bike and broke my hand recently, and the whole thing, well, not the whole thing, but had exactly the same. I had to hold my hand up to the camera yesterday and press bits to see if it hurt. So this should never happen before. Now then, obviously another fan of yours here, Elizabeth Howell from Wales, and she's saying, living in Wales, I benefited from Don's support to inspire the 1,000 Lives programme. So my question, it feels as if the focus still is overwhelmingly on secondary care, and actually lots of people have asked a similar question. How do we ensure that the primary care services are better supported and managed than they have been before? Because all the focus has been on secondary care, but yet we know that avoiding the possibly inevitable second spike and all that is going to be so much the responsibility of primary care that seems to have been kind of almost overlooked in the last 4 months.
Indeed,
So,
it has.
pat on the back from Wales, but then a tricky question.
Yeah, well, hello to my friends in Wales. Exactly. This is a matter of some concern. Again, Simon, with your questions, I'm always aware how much I know of what's going on in the U.S. and how little about the U.K. So you'll just have to do the translation for me to English to British. Yeah, I mean, our government has now just set up, I think, more than $2 trillion of rescue for organizations that are stressed. Hospitals, for example, are losing a lot of money because their usual sources of revenue from routine care are gone, or at least almost gone. But if you look at the pattern of expenditure, almost all of that money has gone to large institutions, to hospitals. Primary care practices are suffering enormously in the United States. They are fee-for-service based. That's how they make their income, most of them. And we don't have a plan. There's no cogent way to make sure that these practices can survive economically. Similarly, rural and community settings, community health centers have not been the beneficiaries of a lot of this largesse. There's another thing that's related that Ms. Howell didn't mention, but it is related, which is the use of the bailout money to accelerate the changes in design that we really want. Simon Stevens' rather brilliant long-term plan, which I think is a thrilling document. I spoke about it at the RSM last year. You could use bailout to say, and we're going to use that resource to help us get even faster to the configuration that we need in the future. We don't have that kind of strategy going on in the U.S., and I really wish we did.
Well, mention of the long-term plan and your talk at the RSM, which we all remember very well. And unfortunately, we did keep a copy of your slides. And I just want to this specifically about the long. Now, this is what you said about the chances of the long-term plan succeeding. You were very, very appreciative of it, and and I'm going to quote you now. You said that for it to actually happen, much would depend upon the enthusiastic leadership and engagement of healthcare professionals. Not a radical suggestion. And then you said the problem is, quote, how to achieve this when emerging from an era with so much uncertainty, fatigue, pressure, and conflict. And if I then read back to you to say how to achieve this when emerging from the COVID crisis with so much uncertainty, fatigue, pressure, and conflict, your phrase works just as well, I think. So, because I think this is the key thing. It's all very well to say we need to come together, but we all know, we're talking this morning in the press about moving towards the independent investigation, the commission, whatever, and we know whoever runs it, there will be conflict. We know that our senior staff and our junior staff who performed admirably, but are frankly exhausted now, and yet more pressure is coming and the uncertainty about the future remains. So if that was a problem when you gave us the talk 2 years ago, it's even more the problem now, isn't it, Don?
I don't want to be glib at all about this, Simon. I mean, the pressures are enormous. My daughter is a hospitalist in a Boston hospital, and I can see over time, the burden is enormous. So I know I'm not being dismissive at all of what you're saying. And we need, and by the way, we do. I think one thing to keep in mind is there is a behavioral health and mental health need in the healthcare workforce that must be met now. We're human beings under enormous stress. need help. And so there has to be a strategy for reaching out and offering the psychological supports and the helps that we possibly can, in addition to the physical support and equipment and encouragement that people need. So I'm not being dismissive of that, but if you zoom out for a minute and look at kind of what the lessons here are, it does have to do with integration of effort, with being on a team. That we say in IHI, never worry alone. It's the coming together that is I mentioned in response to Simon's question earlier. It seems to me so hard and so important here. To connect it to the long-term plan, the long-term plan has a vision in it of finally, really, after 70 years of the NHS, realizing that place-based, community-based care design, where you have integrated systems that really take care of populations, merging across boundaries, is a much more powerful way to do this than in fragments. The same is true of the COVID stresses, and so I think the NHS will end up in a better place if it can move toward this place-based, population-based designs, and physicians and nurses and clinicians, as well as managers and politicians, come together and say, how can we work better on behalf of the population? That's a tough reach, I know, when people are under stress, and that's why I risk being glib here, but it is the answer. You're just better working together than separately. That's where you'll find the energy to survive.
Yeah, I mean, it is difficult though, Don, and these are practical things happening as we speak, is that, and this is now talking about the health of the workforce. I mean, on the one hand, the physical health, you wrote that the physical safety will need to be prioritized more. And clearly that's the case. We can't go through some of the confusion and mess we had with PPE, which also not only does it affect physical health, has a massive effect on mental health where people don't feel protected. We take that as a given, though it may not happen, but it needs to happen. But the more complicated issue is the issue of you said that we need to prioritize the emotional safety of the workforce. Now that's a tricky concept, actually. Can you just elaborate what the word emotional safety means? This is from your JAMA article.
Well, it means a couple of things. One is the simple, the design that makes people feel accompanied, that I'm with you. And so if a physician becomes depressed or isolated or overwhelmed, somebody knows it, somebody sees it, and there's something to do about it, to reach out help. It could be formal mental health care. It could be group processes that allow people to support each other, but isolation is the enemy of mental health in this case. And so that can be managed, that can be led. Organizational leaders have to be able to say, if you're in distress, if you're unhappy, if you're sad, if you're starting to think about suicide, here's what to do with that. You're not alone. We're here with you, and that's not soft. It's not touchy-feely. It's necessary, and it's humane, and it is healing. The larger level goes back to the equity issue, which is the case that people of lower income, people of color, African Americans in our case, are especially vulnerable. They have less, if they're a lower income, they have less flexibility in their lives, less ability to make some choices about staying home or adapting to this than people of higher means. And so this is a time of challenge to say, we have to understand that every cleaning person, every person serving food, every person in healthcare, the drivers, the people parking our cars, they are the healthcare workforce, and we have to really reach out to them as well. That's a big ask, but it's really important.
Yeah, no, we couldn't agree with that. And
there's one other thing. If I'm sorry to interrupt you, Tim, but this is going out on a limb, but I'm going to go there.
You're among friends.
In your country and mine, there is a unfortunate tendency to say that the problem is that we have to put someone's head on the platter, that we have to find who to blame, do the inquiry, and get the miscreant corrected or out of the picture. That isn't going to work here. It's just not going to work. And you can inquire all you want about who screwed up. That is not an answer to the problem as to how do we build our way out of this disaster. And I sometimes lament the headlines I see in both your country and mine when it's all about finding the true root cause. Now, in my country, there's one exception, and it happens to be the occupant of the White House. So that's a very unusual. Most of the time when things are going wrong, it's good people trapped in, as you know, in systems, which is what the main point we tried to make at the mid-staff situation.
It is, Don, but truthfully, though, I would say that is a little King Canutish at the moment. I mean, if I was, not just Simon, but also, our chief advisors, a medical officer, chief scientific officer, the people at PHE, in all our various agencies, all of them would obviously say aye to that, what you just said, but they would also say that's not going to happen. And we can already see people starting to take sides and starting to pass the buck. I mean, to say you shouldn't do that, it's just, it's going to happen whether we like it or not. And it's the best. How can we make sure it's not too damaging, both to the individuals and to the systems?
Yeah, I guess you're right. It has happened, so it will happen.
Yes.
I think the challenge is to
happening.
leadership, which is when you are in a responsible position, the chief of something or the head of something or the executive of something, please keep this in mind, that may be in the environment, but your job as a leader is to encourage people, not discourage them. Your job is to offer support, and if something went wrong, to grow knowledge. And I think leaders can buffer this toxic environment to some extent. You're totally
Well, I
right.
hope
It
so.
has happened. It will happen. But most people in
Yes.
healthcare, they're trying darn hard to do the right thing.
I don't think anyone disputes that, but nevertheless, that will be forgotten. Now, I've been asked to remind everyone that we have scheduled this for till 1:15. I hope you did know that, Don. I'm hoping that we can go on. You did. Thank God. It's just me who didn't, and I've forgotten. Okay, so folks, there is still time. There's no way we're going to get through even 1% of the questions that are flashing past the screen. But I did see one, and I'm afraid, I've got it still there, Michael Jubb, and I recognize that name actually, but anyway. And it's not a question that anyone's ever asked before, therefore I thought I'd ask you. And this time it's closer to your home than mine. And he says, given the success of the Cuban healthcare system in combating COVID, and I wasn't simply aware that that's the case, but he said, what lessons can we learn from that? So I assume he's right in what he says. But no one's asked about the Cuban. We discussed it. We discussed Switzerland, Sweden, Singapore, but we've never mentioned that.
I don't know. That's news to me, I must say.
It's news to you.
I promise to look into that. The countries that do appear to have been
Okay.
more successful, and it may be the case in Cuba, it's a tempo thing. They got ahead of it. They acted earlier, even acting a week or two earlier. That is, anticipating this made an enormous difference in outcomes and stability. I think the other thing is systems designs. For example, countries that got more quickly to large-scale testing or testing and tracing, countries that were able to organize supply chains faster or were prepared to do that, they did better. So there's something about anticipation, and whether that was true in Cuba or not, I don't know. I certainly will look into it. I appreciate the tip.
Okay, well, you got us there, Michael, but as a general rule, again, though, I think Cuba is famous for its very strong, decades-long investment in primary rather than secondary care services. I think that's reasonably correct, isn't it, Don?
Yes, and to track and trace that's a community-based effort. You have to get out to where the case is and be able to do the correct investigation.
Now that brings us to a series of questions Fiona Moss has asked and many others, and I'll try and put them together. But I think it's fair to say we've always thought we had a good public health system and in a primary care system that we believe, I think correctly, is second to none in the world. Certainly, I have to say, better than the US. I mean, it's just an article of faith that we have that. And yet, something has gone wrong over here. It hasn't worked as it should have worked. And the track and tracing system that we assume they have in Cuba, that we know they have in Germany, and we know they have in other things, just cannot and still hasn't got going. And the headlines this morning are that the service was going to be set up with Serco and then with, who was the other one? I've forgotten the other company, Deloitte's. Hasn't been working, and therefore we've now reached out to McKinsey's, was announced last night, have been brought in to try and sort it out. And what has happened here, Don? Where did this go wrong? Why are we not? We should be ahead of this game, and we're behind it. Is this due to the Lansley reforms, of which you know exactly what I'm talking about? Is there some structural problem that we don't know about? But something's gone wrong.
Again, I caution that I know less about the UK than the US. I'll
You
answer in the
don't,
US
Don.
context
You
in a
know
minute.
you
But with respect to the Lansley reforms, I mean, I've said this publicly and I believe it,
don't.
that the NHS, in order to function properly, cannot work from Whitehall to the community in one direct step. You need intermediate organizations like your old regional health authorities or strategic health authorities,
Yeah.
and that got you kind of lost that thread. And so it was like from Whitehall trying to help the service with 3 layers of mittens on. There wasn't a sense of what was happening really at the front line. I think that you're en route to correction. These integrated health systems would be one answer there, and some regional structures would really have helped. You can't manage from 1 to 50 million in one step. It just doesn't work. In the US, I'll tell you the phenomenon. You can tell me if it's true with you. There's a wonderful book written by the great scholar of public health, Carr White, called Healing the Schism. And White's thesis is that for historic reasons, we ruptured connection between the public health endeavor and what you might call social care also in the US, and the delivery of curative health care, of the repair shop, as I put it. The schism is between public health and healthcare delivery. That's not smart. There needs to be a unification of endeavor, by which I mean the general practices of your country are a public health tool. They're a public health resource, but only if they're trained to do that, only if they're resourced to do that, only if they self-image affects that. So you could have, if you had chosen, set up a GP system in the country, which could be called into play for the preservation and improvement of public health, including even surveillance and contact tracing, or at least exchanging data. You didn't do that. And as the NHS fell under more and more financial pressure, that got worse, not better, because what happened was I saw your leaders said, well, we do have job one. Job one is to run our hospitals and care for people when they're quite sick. Social care, causes, and even public health, that's not job one. And so as the resources get strained, that gets stressed. You can correct that. You can correct that anytime you choose, and get ready for the next pandemic much better with indeed one of the strongest primary care systems in the world. One of the great things you have in the UK that looks obvious to you because you don't realize how special it is empanelment. The idea that you actually can, at least in principle, tie every single person in your nation to a general practice. That's a tremendous resource. I mean, one of the whole problems in case tracking is you don't know where the people are. Empanelment it's a jewel of a lever for proper public health.
And yet somehow we've ended up people going to be tested at kind of remote car parks in decaying industrial estates instead of in the surgery around the corner. It is baffling, isn't it? I mean, someone else is asking, do you think this is just in a crisis? Most leaders, not just of healthcare systems, want to control and therefore turn to the kind of organizations, to bring in a new organization to do it from fresh. Do you think that's just a fundamental of crisis control, that you want to be in control and this is not the time you're going to devolve responsibility down to the local areas?
Well,
that seems to have happened.
You need decisiveness, obviously, in a crisis. You need someone to say, let's take that hill. But that's not the question. If, for example, the primary care system, as you said, Simon, in the country were harnessed as a public health apparatus, then you could control that. You say, hey, everybody, pay attention. This is the time when you, GP and, Penzance, you now have, remember that I told you that part of your job about contact tracing or dealing with your panel. Let's trigger that now. So it doesn't mean centralization. It just means clarity, and that a good leader does that.
Yes. Maybe we still will do that. I've heard also other things.
You could. I can't speak for the GPs in your country, but they're under a lot of stress also. And
yes.
This is fulfilling. This is, I believe, as a GP in your country, to be called to your mission during a crisis it's an inspiring thing. It's not a matter of puppetry. It's a matter of becoming part of the team.
And let's be clear, GPs are also working harder than before, have also innovated in an extraordinary way in terms of electronic and digital, and are the ones also attending to, I think we'll find out that one of the biggest causes of death, we are finding out, is people not being treated for all the other things. And much of that now is going on in general practice. Okay,
you have to also reach the care homes, and I don't know how you would do that other than through the.
I think that's a separate comment we'll be having later. But let's then go on to the big other burning question. They are related. The 15 genes of the SARS-2 virus have done one other thing that the 30,000 human genomes have not managed, genes of the human genome, and it is to shine this spotlight on where you began, on inequality, injustice, obviously the George Floyd murder, and it is just as ever, COVID has not created something, but it's accelerated and brought to the fore the issues around ethnic minority, the marginalized, incarcerated, and so on, which is, I'm quoting you now. So, but what I want to do is to use the American phrase that I learned from the US Army, is that we spend a lot of time admiring the problem. And in my world, in mental health, we've been admiring this problem now for all my career, that Black people are much more likely to get sectioned under the Mental Health Act than a non-Black. That's been the case since I started. I spent 2 years writing a report on it. It's still the case now. Do you think this has given us any clues as to how we might reverse this tendency? It's shined the spotlight for sure, but do you think it's left any clues as to what we might do?
Maybe, I hope. Yes, we in the US and you, I guess, in the UK have been admiring this problem for a long time. For us, it goes back to the 17th century and the way our country adopted slavery as a basis for its economy, and this is still slavery in a new form. And it's the problem is it's structural. It's built into so many elements of our society that the disadvantage of people of color, it seems almost inevitable, and it will not change until we decide to change it and invest where we need to. And by the way, shift power toward communities of color so we can work together instead of fixing them. That's just not even close to the right answer. Will we do it? I don't know. Nobody in the field of health, public health, as I am, could be the slightest bit surprised by the inequity of suffering in the COVID crisis. Of course it's there. Of course. We knew, and it was there before COVID came. How to solve it, Simon, I don't know, but there has to be a public policy decision to do this that is monitored. There has to be accountability for it. I hope we have a new president who will take this into the Oval Office and say, in my time, we will make tremendous progress against structural racism. It appears in the institutions that you mentioned, in our schools, in our criminal justice system, in our housing policy, in our police behaviors, and so it's all of government. This is not a healthcare issue. It has to be dealt with across all of government. What's paradoxical to me, what's sort of puzzling to me, is I learned this from Brits, the Black Report, Sir Michael Marmot, Harry Burns, and his eloquence in Scotland. It's you guys who really have given the science, but you've probably done more for the science behind inequity than any other nation. And yet the Marmot, you just issued the Marmot report 10 years after the Marmot report, the follow-up report. I mean, to be blunt, very little has happened, and it's time to change that. I was hoping you could tell me the answer because I really need it.
No, this is a man who claims to know nothing about our healthcare system. Okay. Then the last point that you made in the JAMA paper, and I think it'll be the last point, well, bar one that I want you to make here. Now, you have the phrase assume abundance, which is you don't just mean money, but about using all the assets that you have. Now, at the moment, money has not been the rate limiting factor in our response to COVID. Indeed, the kind of the quality system that we had, NICE and QALYs and how we're not allowed to use the word ration, but it is what we do, how we come to some limit as what we can spend on what, has gone out of the window. If we were to do a QALY now, rather than the limit of 30,000, it would now be close to 1 million, I think. So it's completely gone out of the window. But as they say, money talks, and very soon money is going to be saying goodbye. What are we going to do next year when the economy starts to, assuming economic forecasting is correct, and we have what we think we'll have, when we really do run out of money and our bonds can't be sold, et cetera, then abundance goes. What comes in its place, Don?
Well, there's other kinds of abundance than money. Ideas, spirit, intent, respect. Everyone in the National Health Service wants to help, and they can be invited to help. So it's coming together and telling people, you're smart, you're good. What do you know that I don't know? And celebrating the ability of people to begin to invent and problem solve as far as they can within the limited resources you will inevitably meet. Abundance of spirit, as soft as that sounds, is so crucial. And there is, you still have a sense of love and pride for the service. That's not going to go away when the budget goes down. It's the resource that's left when the budget goes down. So it's a matter of coping. I just mentioned I've just finished this book, The Splendid and the Vile, which is about a year in Churchill's leadership, and it's quite a story about a nation that, despite stresses beyond anything COVID's ever had us, said, we are who we are, and we will get this done. And it's sort of the same thing with the NHS, I guess. Well, that sounds pretty poetic, doesn't it? But it is the answer. There's never enough money, by the way. There's never enough money. I've never seen anyone ask for less. So
that's true.
Start where you are.
Never enough money. That's true. Okay, now my last question is that you, on one of your many, many visits, you came over here and you wrote a very powerful report on mid-staffs and a promise to learn, a commitment to act. And you did something I've never seen anyone done before. You ended with 3 letters from you. One was to the senior government officials and senior execs in the NHS. One was to the people of England. And your last one, and by the way, if people want to read this, it's highly accessible. A promise to learn, a commitment to act. We'll put it up in the further reading that we do after each of these webinars. So we'll put the link up for you. But I suggest reading those 3 letters. So the third letter you wrote to the clinicians and managers and staff of the NHS. If you were to write that third letter today with the aim of continuing the energy of change that we've seen, and what would you say to the clinicians, leaders and staff now? How would you write that letter now?
Well, I'd begin with thank you. I think people really are digging very deep right now to do the right thing, and the conditions of stress you talked about. So it would begin with enormous gratitude. Yeah, I guess, I don't know, Simon. I guess I'd say, please think of the next generation. I continue to believe that the NHS is sort of like it's some kind of chalice, some kind of work of art that right now you, the clinicians of the country, you hold in your hands. You are it. And yes, you feel out of control sometimes, and instructions come that you don't understand. But you are it. You are holding this thing. You will pass it on, and manage it gently. You have to think about what you would like to pass on. I think the ongoing potential for growth and development in the NHS, it's still there. COVID didn't change that. COVID made it more important. And so think about the NHS you want to create together and do it together. Yeah, it's what a gift you've been given, and you're going to pass that gift along.
Well, Don, what a gift you have given us over the years, and I'm quite certain you are the gift that keeps on giving, as we say over here, and we only hope very quickly we will re-establish transatlantic communications, and we also hope that you will be once again part of the way forward in the US, and indeed over here as well, actually. So a question quickly for the audience then. What do the following have in common, which is you, Daniel Barenboim, Yehudi Menuhin, Dwight Eisenhower, Mother Teresa, Bill Gates, George Marshall, Ronald Reagan, and Václav Havel? The answer is they're all actually honorary knights, knighted by the monarch, Don included. Now, it is true that we did once give the title to Mussolini as well, but we weren't doing the vetting properly in those days. So you are in fact Sir Don Berwick. You're not allowed to say that, but we are. So Sir Don, thank you so much for this, and thank you so much for today and what you have done. Now, don't go, but can I also thank everyone for listening? Can I remind you to come back next Tuesday, same time, same place, where we'll be talking rehab, a huge topic, which will probably by this time next year be the topic of COVID. We'll have Lynn Turner-Stokes, Serena Moss-Morris, Felicity Callard, and others for a longer session as well, talking on rehab post-COVID. And as I say, that a talented team for a very difficult question. So ladies and gentlemen, Don, thank you for coming. I know you've got 3 more of these to do today. You'll do them standing on your head, I'm absolutely sure. It's been a pleasure to have you, it always is, and you will be among friends forever with us. Thank you very much.
Thank you so much. Have a good day.
Pleasure. Good afternoon.
Bye-bye.
Thank you.